Good morning, everyone. My talk is on molecular classifications and therapeutic targets in extrahepatic cholangiocarcinoma. Extrahepatic cholangiocarcinoma, the main modality of treatment is surgical resection, where risk of recurrence is high. It's like more than 65%, and which relates to 5-year overall survival of nearly 30%. The unresectable cases constitute majority of extrahepatic cholangiocarcinoma, constituting about more than 65% of cases. The current standard of treatment for unresectable cases is gemcitabine and cisplatin as per the ABC trial, which results in median overall survival of 11.7 months. This trial included all biliary tract cancers apart from extrahepatic cholangiocarcinoma. So in view of these statistics, there is a need for understanding of biological mechanisms driving extrahepatic cholangiocarcinoma for selecting molecular targeted therapies. This study, it included a multi-center cohort of 189 cases for evaluating extrahepatic cholangiocarcinoma. In this cohort, surgically resected cases were included, and the formalin fixed paraffin embedded tumor samples were taken for all these cases. Whole genome expression was done in which RNA was amplified and prepared with a kit, and targeted DNA sequencing was also done using hybridization capture based assay, PCR amplified for sequencing. Immunohistochemistry was also done, and here 3 micron thick formalin fixed paraffin embedded tissue sections were taken after heat-induced antigen retrieval, and the following antibodies were used: anti-CERB2, anti-PD1, anti-PDL1, anti-alpha smooth muscle actin, anti-MLH1, anti-MSH2, and anti-MSH6. These 3 for testing mismatch repair, and anti-CK19, anti-HepPAR1, anti-KI67. The structural genetic alterations that were seen in extrahepatic cholangiocarcinoma were as follows. In this series, since it included all extrahepatic cholangiocarcinoma, the perihilar cholangiocarcinoma constituted the majority, that is 76%, and distal cholangiocarcinoma constituted 24%. The median tumor diameter was higher in perihilar cholangiocarcinoma, that is 26 millimeter, as compared to 19.5 millimeter in distal cholangiocarcinoma. The targeted DNA sequencing showed the most prevalent mutations as KRAS in 36.7% of cases, TP53 in 34.7% of cases, ARID1A in 14%, SMAD4 in 10.7%. 6 tumors, that is like 4% of cases, showed mutations in mismatch repair genes, that is MSH2, MLH1, and MSH6. ERB2 mutations and amplifications were more prevalent in papillary histology, that is 33.3% versus 3.5% in rest of the cases. IDH1 and 2 mutations were less common, that is 4.7%, and it has been seen that IDH1 and 2 mutations are more commonly observed in intrahepatic cholangiocarcinoma. TP53 mutations were seen, and it was seen that they were associated with poor overall survival and had higher microvascular invasion. This was structural genetic alterations, and the ones where actionable genomic alterations were seen, and the targeted therapies that could be used in extrahepatic cholangiocarcinoma were as follows. Targetable group of extrahepatic cholangiocarcinoma were about 25% of all tumors. The deficient mismatch repair was seen in 2% of extrahepatic cholangiocarcinoma, so this is less in this case. BRCA1-2 mutation was seen in 3% of cases, EGFR mutation in 1%, IDH2 mutation in 3%, ERB2 overexpression in 4%, CDK4 amplifications in 1%, and HER2 mutation in 5.3%. This is another evaluation where a transcriptome-based molecular classes were defined in all extrahepatic cholangiocarcinoma. So it was seen that the cases could be grouped in 4 clusters, that is metabolic, proliferation, mesenchymal, and immune classes. The metabolic cases were defined in 18.7% of cases, where it was seen that there is alteration in bile acid metabolism. There is HDA-C6 overexpression, HNF4A upstream upregulation, and it was this cholangiocarcinoma, there was hepatocyte-like phenotype was seen. In proliferation class, it was seen in 22.5%. There was ERB2 mutations overexpressions. Those were more commonly seen in this proliferation class. mTOR signaling, cell cycle signaling, DNA repair signaling was altered, and MIC targets. And it was seen that papillary histology had more of proliferation class, and precursor lesions, this intraductal papillary neoplasm of bile duct were more commonly had this proliferation were more commonly seen in this proliferation class. And as compared to perihilar, distal cholangiocarcinoma was more common in this proliferation class. Here in this case, the targeted therapies that could be used for proliferation classes are ERB2 monoclonal antibodies and inhibitors like trastuzumab and pertuzumab. And moreover, this proliferation class could respond better to cytotoxic chemotherapy. The other class is mesenchymal class that was most common for extrahepatic cholangiocarcinoma in 47.3% of cases. So here, this hedgehog, this was epithelial mesenchymal transition was seen, and hedgehog signaling, TNF alpha signaling, TGF beta 1 upstream regulation, high desmoplastic reaction was seen, and it was associated with poor outcome, poor overall survival. And it was also seen that this mesenchymal class of extrahepatic cholangiocarcinoma were poor responders to cytotoxic chemotherapy. Then the other one is immune class. This immune class of extrahepatic cholangiocarcinoma, it had high lymphocytic infiltration, that is more of CD8 plus CD8 positive T cells, and PD1 and PD-L1 overexpression was more common in this immune class, and interferon gamma upstream regulation. So this class of extrahepatic cholangiocarcinoma, the targeted therapy that can be used is PD1, PD-L1 inhibitors like pembrolizumab. And the other ones which can be studied for metabolic class, nuclear receptor modulators and HDA-C6 and SK2 inhibitors. For proliferation class, mTOR inhibitors, CDK4/6 and casein kinase 2 inhibitors. And for mesenchymal class, hyaluronidase, hedgehog antagonists and TGF-beta inhibitors. So this was the 4 classes that were defined in this study. Here in this case, while dividing the cases into intrahepatic cholangiocarcinoma, perihilar cholangiocarcinoma, distal cholangiocarcinoma. So perihilar cholangiocarcinoma, this mesenchymal group was the most common. In distal cholangiocarcinoma, proliferation group was most common. And gallbladder cancer, it was like unclassified in most of the cases. It did not fall into these 4 classes of groups. And this proliferation and mesenchymal constituted some of the cases, 20% and 25%. Intrahepatic cholangiocarcinoma, it's like involving all of these classes, most commonly mesenchymal and this metabolic. The survival was compared in these extrahepatic cholangiocarcinoma between all these 4 classes, and it was seen that in the immune class, this median overall survival was not reached. In metabolic, it was median overall survival was 57.4 months. In proliferation, it was 46.1 months, and in mesenchymal, it was 33.2%. So the worst survival is with mesenchymal tumors. The testing modalities that can be used for testing genetic alterations, this another study defines some of the methods, and it in ESMO Open Journal, and in this case the genetic alterations can be tested by next generation sequencing, NGS. It can be used by a DNA based NGS or an RNA based NGS. Instead of whole genome expression, the targeted NGS diagnostic panels can be used, which include assays using hybrid capture, amplicons, and anchored multiplex PCR. Here, for NGS, tissue samples are required. Another method is immunohistochemistry and fluorescent in situ hybridization, that is FISH. IHC and FISH are simpler methods, like they provide quick results, and but NGS is more accurate. And IHC and FISH can be used for identification of a specific genetic alteration in a sample, like HER2 testing can be done by IHC or FISH, or BRAF on biopsy sample can be tested. Where adequate tissue sample is not there, liquid biopsy is an option, where blood sample is tested for circulating tumor DNA. And it can also be used for detecting acquired resistance to targeted therapy by serial circulating tumor DNA analysis in patients being treated on targeted therapy. This table in this article compares DNA-based and RNA-based NGS. So in DNA-based NGS, sequences that are targeted are genome, exons, introns, promoter regions, and RNA-based, it's transcriptome, exons, transcribed rearrangements. And the alterations that can be detected are as follows: this MSI, tumor mutational burden. And the limitations of DNA-based NGS is that effects of genetic alterations on gene expression have to be predicted. Only hybrid capture-based assays may identify unknown fusion partners. For RNA-based NGS, the limitation is that quality of biopsy material is critical due to RNA instability, and alterations in genes expressed at low level may be missed. So the main applications in cholangiocarcinoma are comprehensive profiling of genetic alterations for DNA-based NGS, and for RNA-based NGS, identification of fusion transcripts, including novel fusions. This denotes this extrahepatic and intrahepatic cholangiocarcinoma, the common genetic alterations that have been found. In extrahepatic cholangiocarcinoma, TP53 mutation, KRAS mutation, ERB223 amplification, SMAG4 mutations, CDK N2A/B loss, ARID1A mutations, PIK3CA mutation, NTRK fusions, MET mutation. IDH1 and 2 is less common as compared to intrahepatic, where it is more common, IDH1-2 mutations, and BRAF mutations, P10 mutation, FGFR1-3 fusion mutation, and MET amplification. The ones in red, these mutations, some targeted therapy drugs have been studied for these mutations. These are the actionable targets, genomic alterations, and what drugs that can be used. This shows in advanced cholangiocarcinoma. So for IDH1 mutation, this is ivosidenib drug, though it's not approved for, it's approved for cholangiocarcinoma, mainly in intrahepatic cholangiocarcinoma. And FGFR2 fusions, these are the drugs that can be used, and it is approved for cholangiocarcinoma. Then MSI, though it is less commonly seen in extrahepatic cholangiocarcinoma, these are the drugs that can be used: pembrolizumab, nivolumab, though it's not approved for cholangiocarcinoma. NTRK fusions, entrectinib, larotrectinib, BRAF mutations, these are the drugs. And ERB2 HER2 amplifications or mutations, this is the prevalence is 10%, and the drugs are trastuzumab, pertuzumab, lepatinib, and efatinib. These are the drugs, though it's not approved for cholangiocarcinoma. Then PIK3CA hotspot mutations, these are the drugs. BRCA1-2 mutations, it's like 3% of cases, olaparib. And MET amplification, crizotinib. Tumor mutational burden, more than 10 mutations per megabase, pembrolizumab is an option. And RET rearrangement mutation, this drug is there. So, this is another table where the same thing, based on genetic alterations, what targeted drugs can be used. This BRCA1/2, olaparib, and EGFR mutation, erlotinib, gefitinib are the options that can be tested in cholangiocarcinoma, and MSI high, pembrolizumab, nivolumab, and tumor mutational burden more than 10 mutations per megabase, pembrolizumab. So these are the drugs that can be tested. Though most of these are in clinical trials in biliary tract cancers or cholangiocarcinoma. So to conclude, based on this data, we can test these biomarkers in our group of patients. We have more of extrahepatic cholangiocarcinoma as compared to intrahepatic cholangiocarcinoma, and there is a need for biomarker enrichment preclinical studies and followed by clinical trials, and also the combination with chemotherapy, radiation therapy, all that needs to be tested for generating evidence. Thank you.